give me a chance to be a part of this interesting IC on ocular trauma. We've seen amazing surgeries by Supriya for interesting IOFBs, but क्या करना है? नहीं, it's not coming. It's not connected. एक बार वापस connect करिए. Yes. I'm sorry for this. But I think, when it comes to ocular trauma, the most important is you need to evaluate the eye, you need to see the eye in detail, you need to see what kind of trauma, you need to see what is, is there a presence of IOFB? If you can visualize it, it's great, but if you cannot, then at least alternative techniques to visualize it. So you're very sure before you're getting into the eye and operating a patient, you have everything ready with you. I'm going to take you through a few important tests which are going to help us to evaluate these patients. There's no financial interest in this presentation. We all know that eye trauma is a leading cause of significant visual impairment, and almost about 2.4 million eye injuries occur every year. Bilaterally visual impairment in about 2.3 million cases, and unilateral loss in about 19 million people annually. It's the second most important cause of visual impairment. Almost one of every 20 patients by an ophthalmologist seen in the OPD can be because of an eye injury, and it's only second to cataract and strabismus as a leading cause of hospitalization. Dr. Karobi has already gone through the BET terminology, which satisfies all criteria for unambiguous standard terminology, providing a clear definition of all injury types and placing each injury type within the framework of a comprehensive system. We've known about the closed globe and the open globe injuries. I'm not going to go through this in detail, but you must understand that 77% chance is there to predict a final functional outcome in a patient. Appropriate counseling contributes to making the correct triage and management decision, prognosticate the outcome of injury, and easy to calculate and has major significance for the patient, the ophthalmologic, and other public health professionals. We know about all the closed globe injuries and the open globe injuries, but imaging is one of the most important things in the management of ocular trauma. Evaluation of the extent of injury, planning of the management strategy, follow-up tool, and medico-legal issues today have become extremely important in such patients. So assess, evaluate, and address. Physical examination is very important. A gentle separation of the eyelids may be required, and avoid pressure on the globe. Assess the visual acuity, naked inspection, and on slit lamp see in detail the periocular structures, the conjunctiva, cornea, sclera, pupil, anterior segment structures, and indirect ophthalmoscopy. 5 most important imaging techniques. X-ray is been the oldest and the gold standard. UBM, B-scan, CT scan orbit, axial and helical CTs, and MRI. This is extremely important when you are seeing a patient with a high velocity particle. You have no clinical evidence of ocular penetration, then I think no orbital X-ray or imaging is required. If there is a clinical evidence of ocular penetration, if IOFB is clinically visible, a plain X-ray can do. In a single IOFB, you may not need any further imaging. In multiple IOFBs, you may need CT. In no IOFB visible, you may need CT scan. And again, in no IOFB, you may need further case-by-case decision. If IOFB is seen, then we don't need any further imaging. X-ray. This is the original method of evaluation and detection of IOFB. This is the first thing I think taught to all residents in our ophthalmology days. A dental X-ray may be more helpful due to bone-free image. A use of a limbal ring is still used to localize foreign bodies, study the orbital fractures, and now it's become of medical legal necessity in some areas. It's commonly performed on ophthalmic patients with a history of exposure to high velocity particles and a suspected or clinically visible IOFB. It's useful in radio-opaque foreign bodies and will not detect radiolucent IOFP such as wood and glass. The standard foreign body X-ray series includes a Waters view, a Caldwell view, and lateral views. Plain X-ray films with Caldwell or Waters projections may demonstrate the presence of the IOFP, but it's not going to tell you the exact location. So the sweet localization technique involves frontal and lateral projections, a foreign body which can be beautifully localized within the globe with a bone-free examination by eye movement. So in case of a foreign body, in the anterior segment, the object will rotate in the same direction as the eye, but the object will move in an opposite direction, opposite to the eye movement if it is located in the posterior segment. Smaller things to just keep in your mind when you're seeing a patient for the first time. Localization using metal locators can be either placed on the eye with a contact lens or sutured to the limbus, which we normally do like a metal ring sutured around, and this may help localizing the foreign body either to the anterior or the posterior segment of the eye. So here you have different images. The first image shows you a teardrop sign, which is seen classically in a blowout fracture. You can see that lower area. Then there is an IOFP which is detected with the help of metal locators. You can classically see the ring that is sutured to the limbus and the IOFP is seen. The next important and effective way of seeing and a non-invasive method is again UBM, but it's a valuable adjunct in the evaluation of small foreign bodies which are mainly in the anterior segment and the pars plana, and in evaluation of the lens and the angle. It may be especially useful for finding non-metallic foreign bodies and also used to determine the depth of a visible foreign body. So UBM again gives you an idea whether there is an evidence of angle recession there or not. If there is an iridodialysis, there is a presence of an IOFP, you can see a cyclodialysis, and you can even see if there is a patient, if the patient is pseudophakic, you'll be able to see the position of the lens, whether it's been damaged or it's in the AC. Ultrasound, I think, is most commonly used by all of us, and it also helps us to detect other important phenomena associated in trauma, which can be hyphema, traumatic cataract, vitreous hemorrhage. You can detect and localize intraocular foreign bodies. You can differentiate between serous and hemorrhagic choroidal detachments, and you can also see suspected posterior exit wounds with associated incarceration of intraocular contents, see the evidence of presence of RD or anything like that. B-scan can have a false negative result in small IOFPs or very large IOFPs, especially if the anteriorly located or irregular. IOFBs of wood and vegetable matter, long-standing metallic IOFBs, you will have a false negative result. A false positive can be in air and gas bubble and lens matters. It's useful tool in localizing IOFP and to determine if the object is metallic. It could be performed carefully in case of an open globe injury. It's useful in determining the extent of intraocular damage, determining the presence of a retinal detachment, double perforation, as well as in detecting foreign bodies not seen on X-ray studies. But it also gives you an idea about the nature of the IOFP, round or spherical, intraocular air or glass. The importance of B-scan, this is very important. B-scan will give you the nature of trauma. It will rule out the possibility of a foreign body. You can try to identify normal structures, and the most important part is that you should repeat a USG before you are planning the surgery for a patient. So scheduled surgery, successive B scans will help you to see the patient and go ahead with your treatment plans. B scans will give you scleral rupture, peripheral retinal tears, choroidal detachments. You'll have PVD with vitreous hemorrhage and retinal detachments. All the associated signs can be seen here again. A presence of a dislocated lens, a presence of an intraocular foreign body in the orbit, which gives you a sharp shadow. The limitations are that it's not recommended in open globes. Surrounding edema and injuries may cause difficulty in doing a scan, unreliable for detection of orbital foreign bodies, poor demonstration of extraocular muscles, limited view of the optic nerve and retrobulbar structures, and scleral ruptures. The next modality is CT scan. Today is considered as having advantage due to its ability of performing multiplanar reformation, evaluating intraorbital structures with simultaneous imaging of the bony orbit, of fractures or any herniations into the orbital contents. So, a sensitivity of 45 to 60% for IOFP, which is less than 0.06 millimeter, and 100% for IOFBs, which are more than 0.06 millimeter. CT can miss plastic, even metallic IOFBs, especially if too wide cuts are used. So it's very important to have small cuts that is about 0.5 millimeter. A helical CT scan is an advantage over the axial CT scan, has a shorter examination time, and images much more superior to the conventional axial CT, has the ability to reconstruct a coronal or a sagittal image without further scanning, and reduces your motion artifacts and radiation, and has a high identification rate for glass foreign bodies. When you have no view of the posterior segment or a suspected globe rupture or a laceration or an IOFP in an open globe and associated orbital of facial fractures, CT becomes the choice of investigation. An axial CT and a helical CT comparison with a glass foreign body. The disadvantages are that it's not readily available in pure or purely ophthalmic setups. Intraocular structures are not well imaged, and it can miss plastic IOFPs. It's avoided in pregnancy. MRI is again very sensitive in detecting wooden IOFPs, controversial in metallic IOFPs, superior image quality of the soft tissues as compared to CT, and ability to generate axial coronal sagittal views simultaneously, and also gives you an answer to the optic nerve damage. But again, the disadvantages that it's sometimes expenses can come in your way, motion artifacts, contraindicated in patients with pacemakers or magnetic IOFPs or cochlear implants. Claustrophobia today becomes one of the biggest reasons for patients not getting into MRI machines, and less effective in CT than CT in assessing orbital fractures. Choice of investigations today also in orbital fractures remains CT and X-ray. In metallic IOFBs, open globe, orbital, you do a helical CT with thin slices. If it's a closed globe, your ultrasound UBM take the chance. Non-metallic foreign bodies, you still prefer ultrasound, UBM, MRI. Penetrating injuries, CT to assess the orbit, sinus and brain damage. And in acute orbital or ocular injury, a helical CT without contrast. Thank you so much. Thank you. I'd like to acknowledge Dr. Muna Bende, Dr. Deepak Bhatt, and Dr. Supriya for giving me such good images.